our faculty will have the right answer for your question. So Dr. Salah, thank you very much for chairing this session.
Thank you very much, Dr. Saud. So as you can see from the agenda being prepared very carefully, so you can see the I would like to welcome all of you to the Cardiometabolic Summit, which is the regular summit we have for the over the years, and we've been part of it. And before I go ahead and take you through the agenda of the meeting and start the meeting and welcoming our speakers, I would like to tell you a few housekeeping points. So when it comes to the questions and answer, all of you, please submit your questions in the Q&A box provided on the platform. Questions will be addressed during the panel discussion session, which will have two. One for the first half of the meeting, day one, and we'll have the second session after the second half. This webcast will be available on demand for 72 hours, which is good for all of you and all of us. Please note that question and answer will not be available during the replay period. So make sure you make most of it during the live session. Please don't record, screen capture, reproduce, or disturb any content of this virtual meeting. And we'll try to address all of your questions during the panel discussion, as we have placed enough time for the panel discussion. Before I go ahead and introduce the agenda for the day one and the first half of the day one, I would like to ask my colleague and close friend, Dr. Saud, who's well known to all of you, to say a few words and introduce himself. Please, Dr. Saud.
Thank you. Assalamu alaikum wa rahmatullah. Jum'a Karima. Thank you very much, Dr. Salah. And I'm Saud Sifri, an adult endocrinologist, chairman of Endocrine Diabetes Center at Al-Hada Armed Forces Hospital in Taif, and a professor of endocrine and medicine at Medical College in Taif University. And again, I'm heading the Saudi Scientific Diabetes Society in the Kingdom. And I'm very happy to be a part of this wonderful meeting, where really it talks about linking the cardiac and the metabolism together. So I think over the coming 2 days, we're going to hear a lot of interesting data. And again, we are going to look into managing our people who has got type 2 diabetes, as well as the cardio-renal metabolic issues. So now we are trying to link things together so that diabetes is not an isolated disease. It has got its interlinked with other systems like the heart, kidney, and others. So I wish you that you would have a very interesting meetings. Remember that it is the time for you to ask questions, and I hope that our faculty will have the right answer for your questions. So Dr. Salah, thank you very much for chairing this session.
Thank you very much, Dr. Saud. So as you can see from the agenda being prepared very carefully, so you can see the first half of the agenda, you will hear lots of evidence, lots of data. And in the second half of the session today, you will see how those evidence will be applied to the real world practice. As you can see, there will be 2 case discussions in the second half. So in the first half, which will start at 5:10, okay, we have 2 talks. The first talk is the precision medicine and type 2 diabetes management, optimizing diabetes diagnosis, prevention and care. And the second lecture, or the second talk, will be about the DDP4 inhibitors, 15 years of therapeutic experience for people with type 2 diabetes and what the future may hold. So we will go ahead straight and start introducing our first speaker, Dr. Daniel Duca. He's a senior scientist in Longfield Tenenbaum Research Institute in Mount Sinai Hospital, professor of medicine at University of Toronto. Dr. Duka, he's an endocrinologist and a professor of medicine in the Division of Endocrinology at University of Toronto. He holds a Banting and Best Diabetes Center Novo Nordisk chair in incretin biology. His laboratory is based in the Longfield Tenenbaum Research Institute at Mount Sinai Hospital in Toronto, and studies of molecular biology and physiology of glucagon-like peptide. Dr. Duka received his training in internal medicine and endocrinology from the Johns Hopkins Hospital, University of Toronto, and followed by a fellowship in molecular endocrinology at Massachusetts General Hospital. His work on gut peptides has been recognized by scientific community for its translation impact, supporting development of several new therapies for treatment of diabetes, obesity, and the intestinal failure. He received lots of numerous international awards. So without any delay, Dr. Daniel Duka is going to take us through how we can make our management precise in type 2 diabetes, and we can optimize the diagnosis, prevention, and care. So please welcome with me, Dr. Daniel Duka. Dr. Daniel, the floor is yours.
Well, thanks very much to the organizing committee and the sponsors for this wonderful opportunity to meet with you virtually. I hope we are on our way to getting together again soon, because I missed the interactions. So I will give you a glimpse of the journey for precision diabetes. I don't think we're quite there yet, but let's take a look at the field and the progress that we've made and where we can apply this knowledge. These are my current disclosures. I don't own stock or equity in any of these companies, but I've had a number of very good interactions with companies developing therapeutics in the field of gut hormones. So if we go back 20, 25 years ago, we did have clinical classifications of diabetes, and we knew that not everyone looked the same, that some people developed diabetes when they were younger, other people had a more rapid course and progression to require insulin. Some people were more like type 1 diabetes than type 2 diabetes. And we gradually began to make these clinical characterizations, probably even 40, 50 years ago. But with the advent of the omics era over the last 20 years, there has been tremendous progress in classifying people with diabetes into various clusters or buckets or archetypes. And as a reminder, for these classifications to be useful for the clinician, they have to be reasonably feasible and available at point of care. In other words, if we're going to see large numbers of people with type 2 diabetes and have actionable information, we can't be sending off specimens and fluids and plasma and DNA and have these analysis in multiple labs that take days and weeks to analyze. It's just simply not practical. So one of the attractive features of some of the clusters that have come out of the analysis from Scandinavia, as you can see here, is that this is fairly simple. Aside from the GAD antibodies, which perhaps is not easily available everywhere, the requirement for age and BMI and A1C and simple calculations of HOMA-IR and HOMA-B, that's pretty useful in most clinics. And we can have these classifications that tell us that some people may not get into difficulty with diabetes complications or may not require insulin. Other people who come back unexpectedly positive for insulin antibodies may actually be on their way to type 1 diabetes. And of course, we have insulin sensitive people or insulin resistant people. But how useful is this? And is this what we call actionable? Can we use this information to make different decisions in the clinic relative to just the standard of care we use now? And that's where I think the big debate is centered. And let's look at some of this evidence. Now, I think what will be clear to everyone is that in a certain period of time, I don't want to say if it's going to be 5 years or 10 years or 20 years, but I think it's likely that in the future, in most Western societies, everyone will have their DNA sequenced. And this may actually happen at birth. And so this will be free, and we will be able to mine the genome for information that enriches our ability to make decisions. What's not likely going to be free will be the proteome or the metabolome or the microbiome or the epigenome. And so we have to understand how much additional information does this add, and how will what we call the exposome or our environment, so our lifestyle, our exposure to pollutants or chemicals, our diet, how much will this modify the information that we receive from omics? And you can see that this becomes quite interesting and complicated. Now, the picture I'm showing you here of one of my colleagues, some of you may recognize James Meigs. He has spearheaded the Framingham diabetes study, which, as you know, has taught us quite a lot about the natural history of cardiometabolic disease. And one can see this paper about 13, 14 years ago. And at the time, we simply had GWAS and we didn't have complete coverage of the human genome. But what Jim Meigs was able to determine from following the people in Framingham and figuring out which people did or did not develop diabetes, and then layering on top of that clinical information, his available data at the time for genotype analysis, he did not find that the information from GWAS or genetic variants enriched the prognostic information that one could simply obtain from taking a family history and looking at the BMI and looking at the blood pressure, et cetera. But that was 13, 14 years ago. Science has progressed. So where do we stand today? And let's take a look at this. And clearly, the biggest areas of progress for precision diabetes have come in two areas. One is neonatal diabetes. And this, I think, reflects the fantastic work by many groups. Certainly, one recognizes the scientists at Exeter, Andrew Hattersley and his colleagues, but people in Chicago and in Europe and others have contributed substantially. And the take-home message here is that if we have a baby less than 6 months of age who has new onset diabetes, often requiring insulin to control the blood glucose, we should immediately ask the question, is this a genetic form of diabetes that might be best managed, in fact, without insulin? And the way to make this diagnosis is to sequence the DNA, and this can either be done through targeted sequencing of the known genes responsible for neonatal diabetes. There's about a little more than half a dozen, or this could be done through entire genome sequencing. Some of your university-affiliated laboratories have this capability now in many medical centers. If not, the group at Exeter has been very generous in allowing people to send them DNA from these individuals. And this can have life-changing impact on treatment, as we'll discuss. The related group of people where making a genetic diagnosis is profoundly important are the people, again, with MODY. And we've known about maturity onset diabetes of the young for 30, 40 years. The work of Steve Fajans, and people were, I think, transformative in enabling our understanding. And then we coupled this to the molecular genetics. And there are actually MODI risk calculators. If you put into your search engine, MODI risk engine or MODI calculators, you can input these various parameters that I'm showing you here: the age of diagnosis, the sex, the BMI, the duration of diabetes, the family history, the time to insulin, and it will give you a probability, a pretest likelihood for the likelihood of having MODI. And obviously, if it's high, if it's 70, 80, 90%, it's probably worthwhile sending that person's DNA off for sequencing. On the other hand, if it's low, one has a very low yield for sending the DNA off for sequencing. So these diagnoses, both the diagnosis of neonatal diabetes as well as MODI, represent perhaps about 10% of the cumulative population that one would see with type 2 diabetes. So that's been a huge win for precision medicine. On the other hand, the 90% of the people that you see every day with heterogeneous type 2 diabetes, we're still wrestling with the value of precision medicine. Now, ideally, one could think of the value of precision medicine in several different ways. Maybe it would enrich populations for clinical trials with targeted therapeutics. Michael Nauk does a lot of clinical trials. He would like to know whether or not the agent he's testing is more likely to respond a priority rather than less likely to respond, so he could enrich his trial for the right participants. So that would be valuable if we could have that information. And in clinical practice, we all see responder, non-responders. Wouldn't we love to be able to know using biomarkers or DNA or the microbiome or metabolome who is going to respond better or not respond at all to an intervention? And we have had ongoing refinement of this ability to put people into these groups. And they are very similar across the various studies. They're basically people who require insulin right away, or people who are lean and insulin sensitive, people who are lean and insulin resistant, people who are obese insulin sensitive, people who are obese insulin resistant. So I think this has been very consistent now across the spectrum of these studies. The question is, how useful or actionable is this data? Can we move beyond the single gene disorders in the 10% of the population to really utilizing this information in our clinical practice and perhaps make predictions on drug responsivity? Now, we know that in clinical trials and in the real world, there's a tremendous variation in how we respond to medications. Even though today we simply generally prescribe medications to an entire population, and we let the outcome determine whether or not we will keep people on this agent or switch. So here you can see the ADOPT study, people on metformin, people on sulfonylurea or rosiglitazone, and one can see that in this population, some people got a wonderful response to every one of these agents, and other people did not respond at all to these agents. So would it not be wonderful and useful to know before we write the prescription who the responders were and make our prescription tailored to that information? But unfortunately, we've made some progress in this area, and genetics can identify, for example, about 0.4 or 0.5% of the metformin A1C response. But is that enough to say, absolutely, I will or will not prescribe metformin? Now, people have moved beyond the DNA information itself. And here's a recent paper suggesting that methylation scores will give some value in predicting the glycemic response or lack of response to metformin. Now, this is a bit more intensive technology. It's a lot more work to characterize the methylome in an individual's DNA. relative to the genome. And in this study, there was some predictive value, not just for responder, non-responder for glucose, but for also predicting the tolerance or intolerance to metformin. And that would be nice to know because, you know, we still see 10, 20, sometimes more people who have trouble tolerating metformin. It would be nice to know in advance who those people are, but it's difficult to envision that carrying out methylation analysis in every single patient is going to be useful and cost effective. So how have we fared adding in, for example, metabolomics to our clinical prediction of diabetes diagnosis or outcomes? And in fact, every week, I would say, I read a paper and sometimes comment on this on Twitter about metabolomics. And the ideal scenario is that we will identify a biomarker that can be used to stratify people, or that a combination of metabolic biomarkers can be used to provide prognostic information that will allow us to make decisions. But if one takes a look at adding in the predictive value of a large number of metabolites on the left versus just going with clinical information here on the right, there's really not a great deal of additional value that one gains from adding in the metabolomics to the traditional clinical predictors. Very much like the publication I showed you from James Meigs about 13 years ago. Now, one of the other important considerations is ethnicity. And many of these studies to date, particularly the genomic analysis, have been carried out in European populations predominantly. But we already know that depending on where one lives and what one's ethnic background is, what's appropriate and interesting in European genetic backgrounds may not be relevant for other populations. So let me show you one of my favorite genes, the GLP-1 receptor. I'm hoping that even Michael Nauk has this as one of his favorite genes. And in European populations, there's very little importance of the GLP-1 receptor for predicting the risk of type 2 diabetes. But if one goes to Japan and Southeast Asia, then this pops up as an important candidate gene in the GWAS studies, and there's considerable variation in the GLP-1 receptor in Asia that does associate with the risk of developing diabetes. So we have to factor this into our consideration, and thankfully there are global precision medicine initiatives underway. So we will gradually move beyond the European and United States as centers for precision medicine and start to include many different parts of the world. And the answers will be different depending on where the information comes from and where the ethnicities are factored into these calculations. So it's very, very important because we can't assume that people in Scandinavia or Great Britain or the Midwest United States have the same degree of predictive information for people who we would see in the clinic in Dubai or in Saudi, et cetera. So this is very, very important in terms of a limitation and a future priority for additional research. So in cancer, it's extremely useful to have information for precision medicine to guide therapy, both to avoid toxicity, because many of the cancer therapies are extremely toxic, but also to guide the response, because it's particularly important to have effective chemotherapy when we're dealing with a life-threatening neoplasm. Now, in the field of diabetes as well, for the most part in obesity, most of our drugs are not very toxic. They do have adverse events. You know, we have a list of adverse events that we review with people when we see in the clinic, but generally they're almost never life-threatening, whereas some of the cancer cytotoxicities can be extremely difficult. So we're really dealing with the responder, non-responder possibility as opposed to avoiding toxicity in precision diabetes. And there is a lot of information that we've gleaned from some of these clinical trials. And it's important to ask if we have information, for example, from genetic profiling, will this information be clinically useful? And can the risk that we identify be modified by other interventions? So this is an interesting example of data from the DPP looking at, for example, lifestyle or metformin, and also adding in genetic risk scores, which determine the risk of developing diabetes. Now, one can see if we have people in the active lifestyle category, so they were exercising and they were getting coaching and they were following a diet, and we know they lost a few kilograms, they managed to modify their risk of diabetes despite the fact that they had a genetic predisposition. Now, one could look at this in two different ways. One could say, well, having that genetic information is useful because it would motivate the person to adhere to the lifestyle. Or one could say, well, maybe that genetic information is really not that useful at all, because if I simply tell all of my patients that they should follow a very good diet and be very conscientious about exercise, then it doesn't really matter what their genetic risk is. And we see actually the same thing in familial hypercholesterolemia. If you have one allele that predisposes you to an LDL increase, we know that vigorous lifestyle, diet, and exercise and some degree of weight loss can markedly improve LDL levels in these patients. So we have to factor in the genetic information together with the information that we can use to motivate people to modify. Now, there are always controversies and criticisms about the use of big data, whatever the omics is. And here I've summarized some of them for you. And to really summarize this precisely, most people feel that this is not yet ready for prime time. We can't walk into the clinic in Germany or Canada or Saudi or the UAE and basically immediately implement the same type of omics information, because it's cumbersome, it's expensive, it takes time, and the added value is not yet clear. And of course, we need something that's simple, that's very easy to generate. We need to have the bioanalytics information. Maybe this will be machine learning generated, et cetera. And we need to have this simple so that the practitioners seeing the person in front of them can immediately look at the value that comes from their biomarkers or from their DNA and say, I know the best treatment for you. And this is a work in progress. We don't yet have this available. There are always answers to the criticisms. It's very small writing here, but what I've tried to show you in the black font is the criticisms or challenges in the field, and in the red font are the responses from our colleagues in the community, from Jose Flores or from Leaf Group or from other colleagues who are constantly striving to implement precision diabetes in a way that's meaningful and impactful in the clinic. So this is the hope. Will we be able to take someone's whole genome, perhaps add a simple biomarker to a simple clinical assessment, maybe autoantibodies and HOMA-IR, HOMA-B, and use that information to tailor our treatment in a better way than we simply do today with standard of practice. And there are consortia that meet every 2 years. There's a joint ADA and EASD committee that is constantly looking at whether precision medicine is ready for prime time. And you probably have read their position papers. They're published in Diabetes and Diabetologia every few years, and they outline how far have we come, what are the challenges, where do we need to focus our priority. And I would say it's still a work in progress. So beyond neonatal diabetes and beyond MODY, we're still not completely there. What has changed clinical practice is personalized diabetes, and that's largely derived from our clinical trial information. So we now have agents, thankfully, and you'll hear more about these from Professor Nauk, that allow us to treat diabetes without hypoglycemia. We have agents that are very useful for the older, fragile people. We have excellent interventions to treat the complications of diabetes with heart failure prevention and reduction of CKD and reduction of myocardial infarction and stroke. But this information about which agents to use in which population has not come from the laboratory. It hasn't come from biomarkers or metabolomics or from GWAS. It's come from the clinical trials that we've done with the available agents. So the challenge going forward over the next few years, and people who do research always like to say, in the next 5 years, and many of us are growing older looking at those 5-year increments, but the challenge for precision diabetes is to be able to add value beyond the clinical trial information to really meaningfully improve our decisions for people with diabetes. I'm optimistic that there will be progress, but we really need to await larger effect sizes to see how important these differences are. So those are the remarks that I'd like to share with you today, and I'm delighted to turn it over to my esteemed colleague, Professor Nauk.
So thank you very much, Daniel, for the nice presentation, and again, crystal clear. And hopefully we'll be able to benefit from those data. I'm sure we'll have loads of questions. We will take those questions at the panel discussion after the second talk. Now we are moving to the second speaker of the day one of session one, which is Professor Michael Nauk. He's head of clinical research at the Diabetes Division of St. Joseph Hospital, Rural University, Bochum, Germany. He teaches at George August University and Ruhr University. He has contributed by vital studies providing a therapeutic potential of GLP-1 and type 2 diabetes. He has contributed to the development of incretins-based glucose-lowering medication, such as GLP-1 receptor agonists and inhibitors of the dipeptidase 4. Additional area of interest includes spontaneous hypoglycemia and selenomas, and pancreatic transplantation, cardiovascular complication of type 2 diabetes, and modification of cardiovascular risk in those with type 2 diabetes with the glucose-lowering pharmacotherapy. He had lots of awards. He got the Ferdinand Patton Award, the Warner Kurzfeld Award, and Paul Langerhans Medal of German Diabetes Association. He published widely in the field, 240 original articles and 130 reviews and book chapters. His publication has been quoted widely on the midline. His H-index is 102. So quite impressive experience and CV there. So we are looking forward to hear from Professor Michael about the DDP4 inhibitors, 15 years of therapeutic experience for people with type 2 diabetes and what the future may hold. Professor Michael, welcome, and the floor is yours.
Thank you for the kind introduction and in general, for the invitation to speak today. You have already read the title, so I will skip this now, show you a glimpse on my presenter disclosures, and start with the agenda. And I want to look back on the mechanism of action and some aspects of the development of type 2 DPP-4 inhibitors. And this is my personal introduction to the field. You can see that there is a patient. He has agreed to be shown on this photo. There is an infusion line. There is some GLP-1 running into this patient's circulation. This is my doctoral student, Nicola Kleine. And for those of you who can read this, this tells you that in the year 1992, this patient woke up with a fasting glucose of like 260 milligrams per deciliter. And 4 hours after starting the GLP-1 infusion, it was like 95, just below 100 in the perfect normal glucose range. And when Jens Holst and Carolyn Deacon received our blood samples from this study, what they measured is total and intact GLP-1. And what you can see that during this infusion, most of the material that was related to GLP-1 that was circulating in these experiments was not biologically active. It was modified, degraded, and inactivated. And this is exactly what DPP-4 does. And if you compare the concentration of active GLP-1 and the total concentration, then you get the impression if you could inhibit this enzyme, you could raise the level of GLP-1 considerably. Similar conclusions can be drawn from experiments with subcutaneous injection. And indeed, many companies came up with a molecule that was able to inhibit DPP-4. Here you see some that later were quite successful in clinical practice. They are all different molecules, some similarities, but there doesn't seem to be one molecular structure that suggests this is the only approach to inhibiting dipeptidyl peptidase number 4. What is very, very similar in all these programs is when you stimulate GLP-1 and measure biologically active GLP-1, in the fasting states, you have low levels. When you stimulate with either an oral glucose tolerance test or a meal, you have raised plasma concentrations. And if you do so after having administered sitagliptin or vildagliptin, you have higher concentrations. In these two different manuscripts, the peak value was 70 picomoles per liter, still very low concentrations of GLP-1, but sufficient to have biological actions. And from this, it was the short way to performing clinical trials. And here you can see a 2-year observation of patients randomized to sitagliptin or glipizide, a sulfonylurea. And as you can see, in terms of lowering HbA1c, both were pretty potent. In the beginning, so like after half a year or so, the sulfonylurea was more potent in lowering HbA1c. After 2 years, this turned around. These were trends not significant. But one important difference was if you initiated treatment with a sulfonylurea, then body weight would rise by 1 to 1.5 kilograms. If you initiated sitagliptin, both on top of metformin, there is a slight reduction in body weight, but certainly no rise in body weight. And what may be more important for many patients is that you see differences in the risk to develop hypoglycemia. And this has been differentiated by age, below and above 65 years. And as you can see with the sulfonylurea, these are the upper curves, you have a raised risk to develop hypoglycemia, in particular in those aged 65 or higher. And if you were randomized to sitagliptin, you could even approach normal HbA1c concentrations without a risk to develop hypoglycemia. And in this case, it was independent from the age of the patient. So sitagliptin and other DPP-4 inhibitors were effective in controlling HbA1c, keeping body weight low, and this occurred without a risk for hypoglycemia. But in the beginning, there were safety concerns. And that was related to the fact that more than 100 biologically active peptides, they were hormones, growth factors, cytokines, are substrate of DPP-4. And the question arose, will DPP-4 inhibition modify their biological function, as it did for GLP-1, and by the way, for the partner incretin hormone, GIP, as well? The next question was related to other exoproteases that were similar to DPP-4, even by the names of DPP-8, DPP-9, and so on. Will DPP-4 inhibition, those molecules, change their activity as well? And what are the consequences? And there were some examples of hematological problems in experimental animals. Also, it was recognized that DPP-4 is identical to CD26, a marker of activated T cells. So the question was, can DPP-4 inhibition change the function of the immune system, for example, raise the risk for infections? And initial observations meant to find a higher risk for upper respiratory airway infections. But then thousands of patients were included and randomized in clinical trials. And so there was information available on those treated with sitagliptin and those non-exposed to sitagliptin, which means treated by placebo or comparator drugs. And very obviously, there was no higher risk for upper respiratory infections or urinary tract infections with sitagliptin as compared to the other treatments. So the initial concern was no longer valid. There was always a concern that incretin-based drugs in general, including GLP-1 receptor agonist, might increase the risk of pancreatitis, pancreatic cancer, and maybe neoplasms in more general terms. And this has been re-examined a year ago by looking at the results from cardiovascular outcomes trials, which are a very good basis for safety considerations. And there we can say maybe there is a very slightly increased risk for pancreatitis. This was not the case for any individual study, but for the meta-analysis. But we can be pretty certain there is no increased risk for pancreatic cancer or malignant neoplasms, certainly not for DPP-4 inhibitors, but also not for GLP-1 receptor agonists. So how important is glycemic control in general? And this has been examined by the UK PDS, and they found an association of mean updated HbA1c and the risk to develop microvascular and slightly less macrovascular complications. And a recent study has looked at this once again. And what they did is they looked at different categories of patients related to their HbA1c as it characterized 1 year, 2, 3, up to 7 years, but the total observation period was 12 years. And let me guide you through this figure. So here you have the line in identifying 1, which is more or less the risk in non-diabetic subjects. And then you have 4 categories of diabetic patients with very good control based on HbA1c 6.5 to 7, up to above 9%. And what this tells you is that if you maintain an HbA1c above 9% for only a year, that predicts a very high rate of microvascular complications. If you maintain that high level of HbA1c, you can see this risk is rising to up to more than 6-fold relative to healthy subjects. And the response is graded, so those with slightly better HbA1c have also a lower risk. And like in the UK PDS, the same phenomenon was observed for macrovascular endpoints, but the impact was not as prominent. So here, under the worst possible conditions, you have a doubling in the risk versus non-diabetic subjects. And the same approximately applies to mortality, which is much more related to macrovascular endpoints than to microvascular endpoints. So now we are living in times where guidelines play an important role. And I think those who have to write recommendations for the treatment of type 2 diabetes in the current times, they really have to pay attention to the fact that there are two classes of glucose-lowering agents, the GLP-1 receptor agonists and the SGLT2 inhibitors, that have shown in large clinical trials, here results from meta-analyses, that they reduce MACE, a combination of myocardial infarction, stroke, and cardiovascular mortality, any of the components of MACE, but also all-cause mortality, hospitalization for heart failure, and kidney-related outcomes. SGLT2 inhibitors are not so good in preventing stroke, but they are better in preventing heart failure complications and kidney-related outcomes. So since these findings relate to populations with pre-existing cardiovascular disease, the guidelines have come to the conclusion that the first question you have to ask when you consider prescribing medications to lower glucose in patients with type 2 diabetes, do you have in a particular patient indicators of high risk or established atherosclerotic cardiovascular disease, chronic kidney disease, or heart failure? And if the answer is yes, the guideline will recommend specific drugs for this subpopulation. And if the answer is no, the choice of medications is slightly different. So here you see what is recommended when the answer is yes. Yes, high risk or established atherosclerotic cardiovascular disease, chronic kidney disease, or heart failure. And if it is a risk for ischemic complications like myocardial infarction and stroke, then GLP-1 receptor agonists are the best choice. You can use SGLT2 inhibitors as an alternative. If the predominant risk is for heart failure complications or chronic kidney disease, number one choice would be SGLT2 inhibitors, but they can be replaced by GLP-1 receptor agonists under certain circumstances. So no recommendation for DPP-4 inhibitors here. However, this fact that there are pre-existing cardiovascular complications in a given patient applies to approximately 30, maybe 35% of the population. And the rest may have the primary target to treat hyperglycemia, but without a risk for hypoglycemia. And then among other drugs, DPP-4 inhibitors, GLP-1 receptor agonists, SGLT2 inhibitors, and glitazones can be recommended alone or in combination. But if you want to minimize weight gain or even promote weight loss, well, if it is about promoting weight loss, then GLP-1 receptor agonists are best and SGLT2 inhibitors are second. But if it is about minimizing weight gain, then DPP-4 inhibitors could be mentioned in this under these circumstances as well. And if cost is a major issue, so if you need to prescribe cheap drugs, then usually we talk about sulfonylureas, glitazones, or insulins. But there will be very soon a time when DPP-4 inhibitors become available as generic drugs, which will certainly impact on their costs, and then this may change. Unfortunately, the cardiovascular outcomes trials with DPP-4 inhibitors have not shown significant reductions in the risk to develop these cardiovascular events like myocardial infarction, stroke, and cardiovascular death. One example is the TECOS study performed with sitagliptin. But what is different in those studies is that an aim of all these cardiovascular outcomes trials to achieve glycemic equipoise, which means no major difference in those treated with DPP-4 inhibitors and without, was almost achieved. And that is very much different from the trials with GLP-1 receptor agonists. DPP-4 inhibitors in mechanistic studies, and this is only showing you a selection of such data, have shown beneficial effects that suggest beneficial cardiovascular actions in human mechanistic studies. So on myocardial glucose uptake, left ventricular function, cardioprotection during ischemia, flow-mediated vasodilation, and so on and so on. So a suggestion by my colleague Francesco Giorgino from Bari in Italy was to plot the effect, the hazard ratio for indicating the reduction in risk for cardiovascular outcomes versus the difference in HbA1c achieved with various GLP-1 receptor agonists. What I have added is data for SGLT2 inhibitors and DPP-4 inhibitors, and they happen to fall on the same regression line, indicating that the larger the difference in HbA1c, the lower the hazard ratio for MACE events is with these agents in the various cardiovascular studies. And this is only true if you look at non-fatal stroke. It doesn't apply to myocardial infarction and cardiovascular mortality. And what this could indicate, at least I will pose the question, is if you use DPP-4 inhibitor and in addition prescribe drugs that would lower blood sugar, couldn't there be a cardiovascular benefit as well? Another interesting question is the role of metformin as a background medication. This was the case in the majority of the trials testing DPP-4 inhibitors for cardiovascular benefits. And if you just look at the subgroup of patients, the larger subgroup that was co-treated with metformin, there was a trend for a benefit. If you look at those who did not receive metformin for various reasons, then there certainly was no benefit. And the overall effect was almost zero. Let me say a few words about DPP-4 inhibitors in special populations, and I will start with those with chronic renal disease. One lesson that we have learned is that some of the DPP-4 inhibitors are renally eliminated, and in order to prevent exposure to very high drug concentrations, there are recommendations to progressively lower the dose depending on the degree of renal functional impairment. And the only exception is linagliptin, which is not eliminated through the kidneys and does not need this kind of modification. But the good news is they all can be used in patients even with severe renal functional impairment. And there may be additional benefits here. So this shows a study with linagliptin, and clearly HbA1c was lowered much more with linagliptin, but not in all patients. There were patients, according to these 4 quartiles, where there was not much effect on HbA1c, but they still displayed a reduction in urinary albumin excretion, like the ones who had a more prominent reduction in HbA1c. Next, DPP-4 inhibitors in the elderly population. And I refer to a pooled analysis of 25 clinical studies looking at the safety and tolerability of this treatment. And what this study showed is that if you compare those using sitagliptin versus those that were not exposed to sitagliptin, the overall percentage of patients with, or rate with adverse events was even lower in those with sitagliptin, and that was certainly true relative to drug-related adverse events, serious adverse events, however, not significant. So there was no single finding that indicated a higher intolerability or toxicity in patients with high age. So tolerability and safety are major issues if you want to treat patients with type 2 diabetes who are at a higher age. Now, let me turn to some recent publications. And we are living in the time of the COVID-19 pandemic. And so a number of experts have asked the question, are there considerations to prefer or even avoid certain diabetes medications in patients at risk or with a diagnosis of COVID-19? And in red, you can see those that support a careful use of those drugs like metformin and SGLT2 inhibitors with respect to dehydration and a risk for ketoacidosis. With glucagon-like peptide 1 receptor agonist, it is kind of be careful, but it can be used. But dipeptidyl peptidase 4 inhibitors or insulin can be used without any safety considerations. So it's among the drugs that probably can be recommended under these certain circumstances. So let me summarize. What I tried to talk about is that DPP-4 inhibitors reduce plasma glucose and HbA1c through enhancing GLP-1 concentrations. This is a glucose-dependent phenomenon and thus not associated with hypoglycemia. There is some slight weight reduction, not comparable to what SGLT2 inhibitors and GLP-1 receptor agonists do. And they are very well tolerable, and the safety profile compared to other classes of glucose-lowering medications is almost clean. DPP-4 inhibitors have their main role in offering benefits associated with lowering plasma glucose at a very high safety margin. And this may, in particular, apply to patients with chronic kidney disease and the elderly population. And last, I would like to tell you a story about a patient whom I have a very special relation to, and she's my mother. She is turning 92 this year, and like 3 or 4 years ago, she developed diabetes at a very, very high age. So I discussed with her primary care physician that I would like to offer her a DPP-4 inhibitor as the primary medication. And he said, no, we have our guidelines. Let's try metformin. And sure enough, she developed some abdominal problems and couldn't tolerate it. So she got sitagliptin in second place. And since then, she has had HbA1c concentrations slightly above 6%, and she's feeling pretty well. She even survived COVID-19 infection 1.5 years ago, almost without symptoms. And she's a perfect example for me as a person that and she has an EGFR of like 55, so she is also compromised regarding her renal function. So she receives a reduced dose of sitagliptin, and she's a perfect example for me for this particular use in the elderly and in those with renal functional impairment. With this, I will close and thank you for your attention.
So thank you very much. And now I will hand over to my friend and colleague, Dr. Saud Safari, to take you through the second part of the day one. Dr. Saud, the floor is yours.
Thank you very much, my dear colleague and friend, Dr. Salah. And I think, again, now in continuation of what we have started almost an hour ago for the first day, with the second half, I'm very happy to go with you through the agenda, we were going to have 2 cases, and those clinical cases are discussing different issues related to patients with type 2 diabetes. The first case is going to talk about a scenario of patients whom they had been newly diagnosed with type 2 diabetes. The second case is going to talk about different special populations where we are talking about elderly patients whom they would need a special management with type 2 diabetes. Then that would be followed into taking your questions, trying to answer in the panel discussion, where I would be joined again with the 2 experts plus my dear colleague, Dr. Salah. Now, in the beginning, we are going to start this session with a case discussion of newly diagnosed patients with type 2, where I'm very happy really to present one of my senior colleagues, Professor Khalifa Abdullah, who's a professor of internal medicine, diabetes at Alexandria University in Egypt. Professor Khalifa had been appointed as a professor of internal medicine at the Diabetes and Medicine and Metabolism Unit in the University of Alexandria since 1998. I'm not disclosing any secrets. So more than 25 years being a professor of internal medicine and diabetes. And again, Professor Khalifa was the past president of Egyptian Diabetes Association and the assistant editor of Egyptian Journal of Diabetes. He's a member of several international diabetes associations, and Dr. Khalifa had participated as a primary investigator in many national and international studies. Again, we would go through Professor Khalifa over the management of people with type 2 diabetes who had been just newly diagnosed. So, Professor Khalifa, you're most welcome, and we are eager to hear from you how to deal with those newly diagnosed people with type 2 diabetes. So the floor is yours, Professor Khalifa.
Bismillah ar-Rahman ar-Rahim. Good evening, everyone. Thank you, Dr. Seferi, for your kind introduction. Actually, it's my honor to be with you today, and I thank the organizer to give me the chance to be with you in this very important summit for the cardiometabolic syndrome. Actually, the previous speakers paved the way for me to discuss my case because they already discussed the principles of management of diabetes. What I'm going to discuss with you today is how to manage a newly diagnosed diabetic patient with type 2 diabetes. I'll give you just 2 scenarios to show how can we change our strategy according to the baseline criteria we have in our patient. So this is my disclosure. Let us start case scenario 1. Mr. Ahmed, a 50 years old asymptomatic male, recently diagnosed with type 2 diabetes during routine checkup. He works as a civil engineer and exercises infrequently. He used to skip meals and have irregular meal timings. He has gained 3 kilograms in the last 3 months, and he is anxious about being overweight. He never smokes. If we look to the data of his clinical examination, his body mass index is 29 kilograms per square meter, blood pressure high normal 138/85. Otherwise, heart rate 72, cardiac examination, nervous system examination, chest, everything was okay. So he's just a male of type 2 diabetes coming for the first time to be managed. His lab findings just revealing a high fasting and postprandial blood glucose and hemoglobin A1C 8.5. He has dyslipidemia, LDL above 100, so he has a high LDL together with high triglyceride level. Otherwise, his serum creatinine, his sodium, potassium, microalbumin, everything is okay, just dyslipidemia and diabetes. So first, when you try to prescribe treatment or to put a management plan for your patient, the first thing is to classify the patient risk. Is it a very high risk individual or just high risk, moderate risk, or low risk? Because putting the risk of the patient will guide you regarding the targets and even the drugs you are going to use, regarding everything, the blood pressure, glucose control, and lipid control. So applying these criteria for our patient, if you use the European Society of Cardiology guidelines, he's not very high risk because there is no 3 risk factors or target organ damage or established cardiovascular disease. Even he's not at high risk because he's recently diagnosed. There is no long duration of diabetes. So we can put it here in the moderate risk. You can even use the other method of risk classification of your patient by using the atherosclerotic cardiovascular disease risk calculator, the American College of Cardiology, filling the data of current age, systolic blood pressure, lipid profile, and so on. So I'm gonna put the data here, and we'll come up with 10 years atherosclerotic cardiovascular risk of 9.7%. So this patient has intermediate cardiovascular risk. Then you are going to put your plan regarding glycemic control. Are we going to use the sequential therapy, starting with metformin, then titrating, then adding other drugs when we lose the control, or are we going to choose the early combination therapy? Let us review the data. Until now, most of the guidelines says that the first line therapy is just comprehensive lifestyle modification and immunotherapy, mostly metformin, unless there is intolerance to metformin or contraindicated. So, and if you don't reach the goal with time, that's to say 3 months or so, you have to intensify your treatment to reach your goal, and so on, to keep your patient at the optimum blood glucose level or targets needed to prevent complication. This is actually a theoretical strategy, because the reality is not it is not actually reaching the goal as the guidelines say. For example, this is a scheme of how our patients are managed. Following initial monotherapy, then the patient was left for a longer period of time to add the second drug. And then when you titrate the dose up, it takes, again, a longer time period. Then to add another drug, it takes actually years. That's why in most epidemiological studies regarding type 2 diabetes all over the world, the majority of our patients are not at goal. Let me give you some evidence or data. This is the Discover program study to show the glycemic control of type 2 diabetic patients initiating the second line therapy after failure of the monotherapy. It's actually a multi-center study, multinational, involving a large number of patients, 16,000 patients, just published a couple of years ago. Now, let us see the data. The mean A1C globally is 8.3%, meaning most of our patients are not definitely at goal. And in our area, the Middle East area, we have the highest median A1C, 8.7%. So the strategy used with sequential treatment by monotherapy, then adding the other drug, intensifying the therapy, it doesn't work in reality, in real life. This study, look at the data. The time needed from diagnosis of type 2 diabetes to start or to add the second line therapy actually around 6 years from diagnosis. So we are leaving our patient for many years before intensification of our treatment to reach our goal. This is definitely called clinical inertia. So this is another study demonstrating the same thing in Cleveland Clinic. They already looked to the data, looking for patients with hemoglobin A1C above the target, more than 7%, for at least 6 months with a stable oral anti-diabetic drug to see the percentage of patients who received intensification. Actually, around half of our patients did not receive intensification in spite of the fact they are not controlled, they are out of goal and taking the medication for 6 months without any intensification. So clinical inertia is definitely playing a role in our clinical practice, leaving our patient not at goal. So what is the impact of this clinical inertia? Professor Knock already showed you some of the data. This is the diabetes and aging study examining the association of various periods of early glycemic exposure and various levels of A1C to see the effect on the long run on macrovascular complication and mortality. And Dr. Knock already elegantly discussed these findings, and I'm gonna just give you the conclusion of this study among patients with newly diagnosed diabetes and 10 years of survival. Hemoglobin A1C level above 6.5% in the first year after diagnosis were associated with worse outcome. That's why immediate intensive treatment in newly diagnosed patient is definitely needed to save our patient and to protect patients from getting complication. Another study confirmed the same events published in cardiovascular diabetology journal, showing that comparing patients in the first year who received intensification to keep the A1C in the first year of after diagnosis, newly diagnosed, below 7%, to those patients who did not receive the intensification in the first year, and looking after that in about 5 years later regarding the impact of this delay in intensification for the complication, cardiovascular complication. As you can see here, a significant increase in the risk of myocardial infarction, strokes, and heart failure, more than 50% increase in the risk for these complications, simply because we didn't intensify our treatment immediately after diagnosis. So we have to change our strategy. We have to change our way of treating our diabetic patient. That's why this may explain why we, in the large trials with comparing intensive glycemic control versus usual control, we didn't see any beneficial or significant beneficial effects regarding diabetic complications, especially macrovascular complication, because in these trials, they recruited patients with long-standing diabetes. That's why they have already had complication, and there is no benefit except if you start early, as in United Kingdom prospective diabetes study. So now, how to overcome clinical inertia? One of them is to start early by combination therapy, not monotherapy approach, because, as you said, diabetes is a disease with multiple pathophysiological defects. So targeting just one defect will not be enough to control glycemia for a longer period. What we want to do is just to do like that proactive approach, just adding the drugs early in the after diagnosis to keep the A1C at target all through the time if you want to improve the outcome in our diabetic patient. You know that different drugs, different classes of drugs acts at different pathophysiological defects of diabetes. So don't target just one defect. Let me give you example here of adding metformin. This is a baseline targeting hepatic glucose production. So suppressing hepatic glucose production, increasing peripheral glucose utilization. If you add early a DPP-4 inhibitor, so you are treating the beta cell defect, treating the augmented glucagon secretion in type 2 diabetes, and also improving the outcome regarding improving incretin defect in type 2 diabetes. So by a combination of just two drugs, even in one tablet, can target 5 out of the 8 pathophysiological defects of diabetes. And this has been shown in a study, verified study, with early combination of metformin plus a DPP-4 inhibitor, showing that this strategy has been associated or have led to a better durable glycemic control compared with a monosequential approach by using metformin, then adding the DPP-4 inhibitor. And they came up with the conclusion that early intervention with combination therapy provides greater and durable long-term control compared with the current standard of care initial monotherapy in type 2 diabetes. So the strategy of early combination already have evidence from the trial. And that's why in ADA guidelines, the recent ADA guidelines, they stated that early combination therapy can be considered in some patients at initiation of the early treatment of type 2 diabetes. And I think in the near future, initial combination will be our strategy, preferred strategy. Which drug you have to use? Actually, it depends on the comorbidities, depends on the patient characteristic of the start. So unless you have compelling indication, patient with high with established cardiovascular disease or kidney disease or high risk for cardiovascular disease. So if you don't have these, you can choose whatever you want from the oral anti-diabetic drugs you have, based on the patient characteristics. So our patient here is the example I just gave you. He is worried about his weight. He doesn't want to gain weight, and he has irregular meal timing. So hypoglycemia here is a risk, of course. That's why we have to choose drugs that can fit for this particular patient. So this patient, Mr. Ahmed, received a DPP-4 inhibitor, sitagliptin plus metformin twice daily, and he received, of course, statin treatment because he's above 40, and that's why he has to take moderate intensity statin. And 3 months later, he achieved his blood glucose goals, and he was happy by losing even 4 kilograms, not from, of course, DPP-4, but from the lifestyle he already did. This is a case scenario. Let me do some changes, little changes in the case scenario to show that we can change our plan, our strategy, our drugs that we are going to use if we have a different baseline characteristic. This is our case, Mr. Ahmed again. So let me just, he smokes a pack a day. So he's a smoker now and was initiated on metformin 3 times daily and not reaching the goal. So let us go for his clinical examination. Now the patient has hypertension, being a smoker, and a hypertension now. And if you look his lab findings, he has also albuminuria, confirm it. This will completely change the picture. Now we have 3 risk factors: hypertension, dyslipidemia, and albuminuria, and smoker. Together with target organ damage, albuminuria. So, how can you classify, Mr. Ahmed? Whatever the method you are going to use, this patient is a very high-risk individual. 3 risk factors with target organ damage. If you use the calculator, the American College of Cardiology, you are going to have 26.2%. And compare it with the case scenario 1, just 9%. So this is a very high-risk individual, and therefore the treatment strategy should be different. Going to the guidelines, now we have a very high-risk patient, so you have to use SGLT2 inhibitors or GLP-1 receptor agonists. The patient doesn't have established cardiovascular disease, but have albuminuria, kidney affection. That's why it's better for this patient to add SGLT2 inhibitor with metformin to be on the guidelines and to save your patient. Do we have evidence for this strategy? Definitely. We have the cardiovascular outcome trials with SGLT2 inhibitors showing that this class of drug, this is a meta-analysis, by the way, significantly decrease the 3-point MACE, but this effect or beneficial effect on the MACE is driven by those patients with established cardiovascular disease, not patients with just risk factors. So they are beneficial as a secondary prevention for established cardiovascular disease. How about their effect on heart failure? They have a significant reduction in the rate of hospitalization for heart failure, whether the patient had already established cardiovascular disease or just risk factors, meaning that they are effective in a primary or secondary setting, even if the patient is free of cardiac or renal disease from the start. How about their effect on the kidney-related outcome? The same as heart failure, a significant reduction in the renal outcome, and this effect is there whether the patient have already established cardiovascular disease or just risk factors. That's why patients at high risk of cardiovascular disease or with albuminuria should receive this class of drug to prevent progression of kidney disease and to save even the patient from heart failure. So in the case scenario 2, changing some of the baseline criteria have changed our way of management. So adding SGLT2 inhibitor to metformin, and in this case, you have to use high-intensity statin according to the guidelines, although the LDL level was the same in the 2 scenarios. However, high-intensity statin is indicated because the patient is at very high risk for cardiovascular disease. And don't forget here to use RAS inhibition for albuminuria, and this way you are following the guidelines to treat your patient. So, Mr. Chairman, ladies and gentlemen, let me conclude that clinical inertia plays an important role in delaying intensification of diabetes therapy. Delay in treatment intensification increases significantly the risk of cardiovascular events in patients with diabetes, and the early combination therapy with 2 drugs targeting different pathophysiological defects in patients with newly diagnosed type 2 diabetes led to superior and more durable control of blood glucose than using the stepwise approach we used to use in the years ago. A patient-centered approach definitely should guide the choice of pharmacological agents. And thank you for your attention.
Thank you very much, Professor Khalifa. That was very interesting. You took us through that case. It was really very interesting. And I think I would ask you please to stay with us for the panel discussion. Now, again, we would continue with the clinical cases discussion. And now we are going to approach a different special populations, which is really the elderly patients with type 2 diabetes. How do we manage them in a clinical case discussion? Our presenter and experts at this meeting, it's Dr. Merli Elam, whom she's a Vice President of the Lebanese Society of Endocrinology, lecturer at the Faculty of Medicine, USAK, Beirut and Lebanon. Dr. Al-Alam, she's an endocrinologist working in Jubail at Notre Dame University Hospital, and she is a lecturer at Faculty of Medicine at Holy Spirit University in Carlis. She has been an actual vice president of the Lebanese Society of Endocrinology. Dr. Merli received her medical doctor degree from Faculty of Medicine of St. Joseph University, Beirut, Lebanon. She completed her fellowship in endocrinology at Hotel de France, Paris. And again, she had been training in pituitary disease and got university diploma in her specialty from Paris Sud 6th University. Dr. Al-Alam, again, has several publications and international medical journal with different endocrinology topic, and she had participated in different textbook writers, and she had been again a speaker in many local and international medical meetings and member of advisory board locally and internationally, and reviewers for medical journals in endocrinology. So Dr. Merli Al-Alam, we are eager to hear from you. How do we manage those special populations? So the floor is yours.
Thank you, Mr. Chairman, for this nice introduction. Thank you for the invitation. I'm very happy to be with you in this very interesting cardiometabolic summit. So I'll be discussing the management of type 2 diabetes in the elderly patient. And well, this is my disclosure. And it's true that nowadays it's a privilege for many persons to age and to become old, especially if surrounded by our family. But in fact, for us as diabetologists, the issue of treating diabetes in this specific category of patients has its own challenges and questions. First of all, if I ask you to define elderly, I'm sure that you're not going to give me a unique definition. And you will see also that even international societies do not agree on just one definition about all population. But also the specific population has its particularities, and we're going to see the particularities together. What is the glycemic target when we treat elderly? What are the issues with the different kinds of antidiabetics in the specific population? What about their cardiovascular risk? We'll try to cover all these issues in 25 minutes, and I'll be also presenting an interesting case and discussing it. So let's tackle the definition of elderly. As I said, the definition of elderly or older is itself uncertain. While the IGF uses this adjective to describe those above 70 years of age, the ADA includes all age over 65 years. And the WHO extends the label to people who are 60 years or more of age. So there is no unique medical definition for elderly. And with this, let me present to you this clinical case, and we'll be discussing and coming back to this clinical case throughout the presentation. It's about Mirna, who is a 76-year-old lady, non-diabetic since 2016. She is hyperlipidemic, hypertensive with a past history of recurrent UTI. The last one, in fact, was a few months ago, and this is a common problem for women at this age, was also a history of pneumonia 8 years ago, and osteoporosis. She actually leads a sedentary lifestyle and smokes around 10 cigarettes per day. As medications, she's taking telmisartan 80 milligram, amlodipine 5, Atorva 20, and metformin 1000 milligram BID, and Fosamax. Clinical exam, blood pressure 130/75 milligram of mercury, weight 73 kilogram, height 166, which makes a BMI around 26.4 kilogram per square meter. Blood test, fast fasting blood glucose, fasting blood glucose 165 milligram per deciliter, A1C 7.9%, normal liver function. Creatinine 0.9 milligram per deciliter, which makes an EGFR at 62.1 milliliter per minute. And I advise you all always to try to have an estimate about the creatinine clearance or EGFR, especially in this category of patients. What are the selected clinical considerations when we treat elderly patients with type 2 diabetes? We know that diabetes by itself is a growing pandemic. And as persons with diabetes tend to live longer nowadays, we know that the prevalence of diabetes in the elderly is actually rising. And the elderly constitute a significant proportion of all people living with diabetes. For example, if we look at a retrospective US database study in patients with type 2 diabetes, we find that approximately 50% of the study population was aged more than 65 years, with almost 25% age more than 75 years. And this is huge. However, chronic disease management strategies are often based on evidence from younger patient populations, and there are no specific algorithm for old people. We usually tend to follow what is said for young population. Elderly patients with diabetes have complex health needs, and this must be considered when we choose antihyperglycemic therapy. Over 1/4 of people aged more than 65 years actually have diabetes, and 1/2 of older adults have pre-diabetes. And we know that the number of older adults living with these conditions is expected to increase with time rapidly in the coming decades. There are also some other facts concerning diabetes and old age. If you look at this slide, you see very clearly that older patients are more insulin resistant than younger patients. But also, we know that beta cell function itself declines with age. In fact, we know also that studies have shown that this beta cell function declines with age, and this is regardless of the status of diabetes. It is characterized by the following: an abnormal pulsatile insulin response, a decreased beta cell responsiveness to glucose, but also an increased pro-insulin to insulin ratio and a decreased insulin production and secretion. There are also some other factors related to the patient himself that we should take into account in selecting our therapy, such as the presence of some cognitive impairments, and this is very frequent among old people, frailty, some impairment in the kidney function, but also in the hepatic function, the risk of fracture, the fact that they might not be able to take their medicines alone, they need a caregiver, they have some deficits in the vision, hearing, some other comorbidities, but also, and unfortunately, some of them might be approaching the end of their life. And I think that you agree here, the priority is not just to be very stringent in controlling diabetes, but the priority should shift toward the improving quality of life of the person. And whenever we have in our clinic an old diabetic patient, let's try to see where does this patient fit. And we used to classify these people into 3 categories. The first one is the people who are functionally independent. They are able to live alone. They need maybe no or just a minimal caregiver support. And in this category of patient, we can treat them, we can deal with their diabetes as we do with younger people. The second category is functionally dependent. In fact, here we can face some dementia, some frailty, a limited strength, risks of falls, the need for caregiver support for social and medical needs. And the third category is those who are approaching their end of life with significant medical illness or malignancy. Here, the life expectancy is reduced to less than 1 year. And I think that the priority here is really elsewhere, is try to improve their quality of life and not to be very strict when treating their diabetes. Other factors are also important. The side effect profile, it's very important in old people. On top of the list, the risk of hypoglycemia, but also weight loss. While in younger patients, it's a target to lose some weight, especially in our diabetic obese population. Well, in elderly patients and the risk of sarcopenia, weight loss might be an issue. Also, the cost of the medication, the availability. Are there injectables? Are there oral? Is the patient able to take the medication by himself? The greater sensitivity to certain adverse events, and in some cases, even not recognizing medicines as a cause of symptoms. And this might also lead to some compounding risks. The risk of intensive glycemic therapy is very important. We know from the ACCORD trial that intensive glycemic therapy in people at high risk for cardiovascular disease, especially in those taking many medicines and polypharmacy, might increase the risk for both total and CVD mortality. But as I said also, hypoglycemia is a big issue in elderly population. In adults aged more than 75 years, the rate of emergency department visits for hypoglycemia is almost 3 times higher than the younger population between 45 and 64. So hypoglycemia should be really an issue, and avoiding hypoglycemia should be a priority. Hypoglycemia is also associated with fall-related fractures among elderly patients. And moreover, symptom recognition of hypoglycemia, and we know this is very important, was lower among elderly people. If we look at the overall approach, and it was very well explained previously, as I said, we have no specific approach for elderly people, and usually this is the approach that we adopt for all our diabetic patients. We're starting with metformin and lifestyle change, and I will come back later on to lifestyle improvement. And whenever there is established atherosclerotic cardiovascular disease, heart failure, CKD, we know that the shift goes toward SGLT2 inhibitors and GLP-1 receptor agonists, but things do not stop here. We have also the other classes that find their places, such as the DPP-4 inhibitors, the TZDs, the SUs, the glinides, and I will discuss every one of these classes later on. So here, when we want to intensify therapy and we have to give more than one treatment, or even if we cannot give GLP-1 receptor agonists or SGLT2 inhibitors, or we don't want to give it to specific patients, we should target minimizing hypoglycemia. We should target the issue of the weight. We should consider the cost and access. If you want to limit hypoglycemia, we think about the DPP-4 inhibitors, GLP-1 receptor agonists, SGLT2 inhibitors, and TZDs. But for the weight, and as I said, we do not like excessive weight loss in this specific population. It is unlike younger populations. So let's try to avoid in some patients those medicines that might improve weight and cause excessive weight loss. But also the cost is an issue, and the availability to access the medicines is also an issue. This is a very interesting framework to consider whenever we are facing older patient with diabetes. And I'm not going through the targets of blood pressure and lipids, but as I said previously, try to see where does your patient fit. Is he or she is a healthy patient? Here, I think a reasonable A1C goal should be less than 7.5% and very close to the targets of younger patients. Fasting or preprandial glucose between 90 to 130 milligram per deciliter, bedtime glucose from 90 to 150. Now, if the state is more complex or intermediate, reasonable A1C goal should be less than 8%. With fasting or preprandial glucose 90 to 150, bedtime 100 to 180. In very complex state, poor health, really people approaching their end of life, I think you can even forget a bit about the A1C goal. Less than 0.5% maybe, but the priority is quality of life with higher targets in terms of preprandial glucose and also bedtime glucose. Effect of lifestyle. I said it, for young, but also for old people, lifestyle modification is also a must. And we know from the Diabetes Prevention Program, the DPP, people who were more than 60 years of age at baseline had the greatest improvement in glycemia over time. So this suggests that older persons can still respond very well to lifestyle programs, which is a low-fat diet and exercise for 150 minutes per week. What about the vascular risk in this population? Older adults, I mean by this now, more than 65 years with diabetes, are at risk of having a similar spectrum of microvascular complications as younger people, probably at lower absolute risk if they have their diabetes later in life, which will limit duration. On the other hand, the absolute risk for macrovascular complications is substantially higher than for younger people with diabetes. Those people are at high risk for polypharmacy. They have a higher risk for functional disabilities and other common geriatric syndromes, such as cognitive impairment, depression, urinary incontinence, falls, and pain from other reasons. We should always also insist on smoking cessation, treating their hypertension, treating hyperlipidemia, giving aspirin therapy, especially in secondary prevention in this population when it is tolerated, and also to push for exercise. Pharmacologic therapy. There are few data specifically addressing drug therapy in older adults. But if we have a look at diabetes drug trials, including the CVOTs, we see that they included a wide range of patients with type 2 diabetes, even those who are more than 65 years of age. So the approach, whenever we want to choose initial therapy, alternative, or even combination therapy, should be similar in older and younger adults. All types of oral hypoglycemic drugs and insulin are still, in principle, effective in older patients, although each one of them might have some limitations. In general, oral and injectable agents with low risk of hypoglycemia, and I insist one more time on the risk of hypoglycemia, are usually preferred in elderly population. Do not be scared of this slide. I will try to go through all this very smoothly. We start with metformin. Yes, widely available, inexpensive, a very decent reduction in terms of HbA1c. Cardiovascular benefit well established from the UKPDS study. Extremely low risk of hypoglycemia, and we can combine it with other diabetes therapies. But in elderly populations specifically, we should take into account the risk of GI disturbance, which is also frequent with metformin, but also the risk of vitamin B12 deficiency, especially if they are taking metformin for a long time. And as I said, the moderate weight loss, that might be an issue if there is some frailty. We should always try to adapt the dose of metformin according to the renal impairment. And usually at certain age, there is, in most of the cases, a degree of renal impairment. And we should also avoid it when there is an increased risk of lactic acidosis. For SUs and glenites, they are also inexpensive, usually widely available everywhere. We can combine them with other therapies. They are potent, still very potent in lowering HbA1c, but they still require some residual functionality of beta cells. Sometimes we lack this in old people. The main issue remains the risk of hypoglycemia. DPP-4 inhibitors, excellent tolerance. We have a wide experience with DPP-4 inhibitors, decent A1C reduction, and they might also, we know that they might delay even the disease progression if they are used early. Extremely low risk of hypoglycemia, can be combined with other therapies, not GLP-1 receptor agonist, can be given in all stages of kidney failure. For some ages, we need those adjustments, for other not, and they are neutral on weight. So they are decent in reducing HbA1c, and all the CVOTs, they are safe, interrogation mark for heart failure with 2 agents, Saxa and allogliptin. And in some countries, unfortunately, they are still somehow a bit expensive, but less expensive than the SGLT2s and the GLP-1 receptor agonists. Coming to the SGLT2s, excellent benefit was in terms of MACE with the CVOTs, excellent benefit for heart failure, but also in CKD, extremely low risk of hypoglycemia. And in some cases, even if we are not using them for their benefit in lowering A1C, we are using them for heart failure and kidney issue. Weight loss remains an issue in this population, especially if we keep in mind the risk of sarcopenia in old people, but also the risk of candidiasis. And we saw in our case, the woman who had recurrent urinary tract infection, and this is frequent, and especially in women at a certain age, the potential increased urinary incontinence. When there is renal impairment, they will not lower A1C enough. They need a certain kidney function in order to lower glucose. The risk of euglycemic diabetic ketoacidosis, but also, especially in old people, the risk of fluid volume depletion, especially if they are taking diuretics or if they have any other health issues. But also with CANVAS, the risk of peripheral amputation that was an issue with canagliflozin. GLP-1 receptor agonist, excellent. The most potent probably among all of them in reducing HbA1c, benefit on MACE with CVOTs, renoprotective effect, low risk of hypoglycemia, still an injectable, although it is once weekly and you are waiting for the oral forms. The cons, the weight loss, that might result in sarcopenia, but also the gastrointestinal side effects that might also be a challenge in old people. They are still injectables, and many old people are not able to self-inject the GLP-1 receptor agonist, and unfortunately, they are most of the time and in all the countries relatively expensive. The TZD is widely available, potent, cardiovascular benefit with pioglitazone, low risk of hypoglycemia, generally well tolerated, but we have the issue of osteoporosis and fractures, such as in our clinical case, the issue of fluid retention, and question mark for bladder, the risk of bladder cancer. We will not go through all the insulin that are available, but let's keep in mind that for old people, the privilege goes to the newest insulins. Why? Because of the lowest risk of hypoglycemia. We should always also pick the simplest protocols, not try to combine many pens. They will get confused with the color, with the pens. So very simple protocols, and the shift goes toward insulins that will cause the lower risk of lowest risk of hypoglycemia. What is the prognosis in elderly? Well, the prognosis for seniors with diabetes is worse than for their peers without diabetes. And on average, they tend to live a few years less. In the group of people with diabetes, patients age over 75 years had the greatest risk of having chronic complications, micro and macroangiopathic. These persons are more prone to have myocardial infarction and end-stage renal disease, and they are more hospitalized because of hypoglycemia. The time of diagnosis of their diabetes is important. Why? The prognosis is better for patients who had diabetes diagnosed in old age. These people will have a lower HbA1c. They will require treatment with insulin less often compared with seniors suffering with long-term diabetes, who usually have a higher risk of complications. If we go back to Myrna, well, she was given Janumet, 50/1000 BID instead of metformin. Why we chose Janumet? Availability, low risk of hypoglycemia, decent in lowering A1C, very reduced side effects, acceptable profile in terms of safety in recurrent UTIs, but also cardiovascular safety from the TCOS trial, safe in osteoporosis, acceptable cost, and weight neutral. And when she came back 3 months later, the tolerability was excellent, fasting blood glucose 120, A1C 7%, no hypoglycemia, same weight. We chose sitagliptin in this patient. We have, well, a very important, good data about this agent in elderly people. In clinical trials, sitagliptin showed a decent reduction in HbA1c, an excellent tolerability profile in people who are old, but also in old people with renal impairment. In TICOS cardiovascular safety, well, it was safe in terms of cardiovascular events, but also it was not associated with an increased risk of fracture. In this very interesting study where they tested sitagliptin on patients aged more than 65 years versus placebo, the reduction of HbA1c was very decent, but also very acceptable adverse event safety profile, and no risk of hypoglycemia, neutrality on weight. This is very important. And this is a post-hoc pooled analysis design that evaluated sitagliptin in many scenarios associated with many other therapies. And in fact, the adverse events were excellent. So, and with no risk of hypoglycemia one more time. Whenever we adjust the dose according to the creatinine clearance, such as, for example, what you see here in this slide. And if you see the potency on lowering HbA1c, you see that it preserves the same strength. So you will have the same lowering effect on HbA1c, and whether you have renal impairment or not, provided you adjust the dose. This is also one more time, the primary outcome is the same in TICOS and elderly as in younger populations, so cardiovascular safe, excellent adverse events profile, and a sub-analysis showed that there is no increased risk of fracture, no increased risk of osteoporosis. For all these reasons, Myrna was put on Janumet. So in conclusion, old age is connected with many health problems. Whenever we want to evaluate a patient with diabetes, it's very important to take into account not only the chronological age, but also the biological age, the physical fitness, intellectual capacity, the presence of other chronic diseases, but also the patient's motivation, the support from his family, from the caregivers and his friends. The basis on treating an elderly person is trying to improve or at least maintain the current quality of life. Symptoms of hyperglycemia should always be reduced gradually. We should always avoid hypoglycemia. If the life expectancy is at least 10 years, let's look at these people as if we look at younger age groups. But in people with long-term diabetes complications, maybe we should adopt a more liberal approach, and targets of HbA1c should really be higher than 7%. Seniors suffering from diabetes are more prone to have chronic micro and macrovascular complications, as well as hypoglycemia and frailty syndrome. When we plan diagnosis and treatment in the elderly, we should not only should not only target glycemic control, but also we should always adopt an overall evaluation of the patient's state and look at the patient as a whole. With this, I came to the end of my presentation. I really hope that you enjoyed it, and I want to thank you for your kind attention.
Thank you very much, Dr. Merli. That was really very much interesting. We enjoyed it very much. I'm very happy really to be joined by my dear colleague, Dr. Salah Abu Sinna. And again, those panelists in which we enjoyed really listening to you. You took us through different populations, and I think they would get the benefit as long as we are evaluating them and doing it in this. So in this cardiometabolic summit for the day one, I think we have reached the end of this. And I would leave the final two comments for Dr. Salah Abu Sinna to just say and to conclude with our first day. Thank you very much.
Thank you very much, Dr. Saoud. And I would like to thank all our speakers who took us through the up-to-date data at the beginning with precision of diabetes management. Then we've been taking about the long years experience with the DB4 inhibitors and how they change the management of diabetes and their safety. And again, Professor Khalifa and Professor Merli, who took us through clinical practice cases, how we apply those evidence to the real life, what we do on a daily basis. And at the end, with the Professor Merrily take us through very fragile population, we call them a special population. And probably one statement I want to add regarding those population, us healthcare professionals, we are very good in adding medication, but we are not very good in taking off medication. So more than often when you see them in the clinic, the average medication they are on is 10. Half of them are not important at all. So we have to keep the necessary medication. So please don't forget that. And at the end, I would like to thank my colleague, Dr. Saud, our speakers, the organizers who kept the meeting going for the last, at least the day I started on board with this, almost like 7 years now. And to our technical team who get us through the first day very smoothly without any technical issue. And all of us, myself, Dr. Saeed, speakers, the technical team and the organizers, we thank our audience who make that interactive and interesting. So thank you very much again.
Thank you.
Thank you.
I think there were a reminder, Dr. Saeed, for tomorrow, 2 slides you maybe need to go through. Thank you.
Okay, so this is our agenda for second day. And please stay because I think you are going to hear even more important issues and discussions. And I think you're going to hear a lot about SGLT2 and then the other things in patients who has got diabetes type 2 with other comorbidities. And again, with this faculty whom I'm seeing in front of me, I think you're going to have a very interesting day. So tomorrow we are starting at 5 p.m. Dubai time. And hopefully you would enjoy the whole this. Just a small reminder again that you have got on-demand replay for this. So the webcast will be remaining from 19 GMT time on Saturday, March 19 for 72 hours. Remember that the Q&A and the panel discussion might not be available during the replay period. So you can download it at any time on demand and see it. Again, thank you very much for my dear colleague, Dr. Salah, for the speakers, for the experts. We have been the whole day on this and it was very much interesting. Again, thank you very much for the organizers, MSD. And again, thank you very much for those technical support that we had during the meeting. Thank you very much and hope to have a very interesting day for tomorrow. Thank you very much.
Thank you.
Thank you.
Thank you.